but
Sure.
but we can start with a round of introductions. So I'm Neil Datta. I'm the secretary of the European Parliamentary Forum for Sexual and Reproductive Rights, which helps support the Global Parliamentary Alliance on Health Rights and Development. I'm based in Brussels, Belgium. Maybe you can go next, Priya, and then call upon the next person to introduce.
Sure. I'm Priya Balasubramaniam. I'm a senior public health scientist with the Public Health Foundation of India. I also direct the Center for Sustainable Health Innovations. I'm part of a broader thematic working group on the private sector on health, which is helping co-organize this particular dialogue. So a pleasure to meet you all. I'd like to now call upon one of our speakers, Mr. David Clark. Would you like to, David?
Thank you, Priya. So I'm David Clark. I work for WHO in Geneva. I'm a public health lawyer. I lead the institution's theme work in WHO in the Health Governance Department. One of the thematic issues that we work on is the private sector. And I also am the focal point for work with the Interparliamentary Union. It's very nice to join today, and I'm really looking forward to participating in the session with you all. So over to Phyllis.
Okay, hi, thanks. My name is Phyllis Awor. I'm a public health physician. I'm based in Uganda at Makerere University School of Public Health. I am on the Health Systems Global Working Group on the private sector with some of my colleagues on this call. And it's a pleasure to speak with all of you today. Over to, I'll take Jerry, that's easy for me.
Sure, I'm Jerry Bloom. I'm based at, well, I'm a co-convener of the Health and Nutrition Cluster at the Institute of Development Studies in the UK, and I'm working with colleagues on the thematic working group on the private sector of Health Systems Global. Shall I name something? I mean, along the top is Professor Enver Roshi.
Hi, good morning. Do you listen to me?
Mm-hmm.
Yes, we can hear you, sir. Yeah.
Okay, I'm from Albania. I'm the head of the Health Commission in the Parliament of Albania. Unfortunately, that 2 weeks ago, I passed a very critical situation of the COVID-19. I was in a critical situation in the intensive care, but now I'm okay. That maybe when I speak, I feel some tired if I speak long. But I will be following you here. It's a pleasure to be with you, and some of you I know I met before. So it's a great opportunity for me to learn about the PPR in other country. In Albania, we don't have a lot of experience of the private partnership and others in the health sector, but it's good opportunity also to see your experience and how our legislation can fit or can do as a parliamentary to help or to profit from private health sector to the state health sector. I mean, to be together and to help the people and to meet the people's needs. Thank you very much for being with you. Thank you.
Thank you, Professor Roshi.
Thank you.
May I call upon Honorable Pasaris to please introduce herself.
Good morning, everyone. My name is Esther Pasaris. I'm a first-time member of Parliament. I represent the county of Nairobi, which is the capital city. I was a member of the Health Committee for the first 2.5 years of my tenure. I've now moved to Private Investment Committee, but I'm very much connected with matters health, given that the highest population in the largest county is Nairobi. And I'm honored to be here with all of you.
Thank you. I can see, may I call upon Dr. Weisbacher? Suzanne, please introduce yourself, and then we can go to Lolem.
Hello, everyone. My name is Suzanne Wiesbacher. I'm the Global Head of Access to Medicines with Takeda. And we are very engaged in health system strengthening, in particular in low and middle income countries where we have many underserved patient populations. It's a pleasure seeing you all. Looking forward to the discussion.
Hello, Hello, everybody. My name is Lola Mgong, and I'm with AMREF Health Africa. I'm the Chief of Staff. And AMREF basically, I call ourselves a one-stop shop for public health, of course, very much tied to building resilient community health systems. Thank you.
Thank you, Lola. And I believe last but definitely not the least, we have Honorable Mary Effa, who is the chairwoman of the Parliamentarian Forum. May I call upon Honorable Effa to please introduce herself. I think there might be some technical. So. Honorable Effa, would you please do the honors of introducing yourself? I think we need to do a little bit of a sound check because I'm not very sure if she can hear. Can you hear me, ma'am?
Marie-Rose, est-ce que vous pouvez nous entendre? Honorable Marie-Rose, est-ce que vous nous entendez? On vous demande de vous présenter.
Okay, I think there's some problems with the volume, but we do have.
I can hear you, and hello,
okay.
everyone.
You have Madam.
David.
Okay.
Can you hear me?
Yes, I can hear you,
Okay,
ma'am.
my name is Marie-Rose Guinefa. Thank you. My name is Marie-Rose Guinefa. I'm chair of the African Parliamentary Network of Population and Development, and I'm a member of Parliament of Central Africa.
Thank you, ma'am. We also have Ms. Sujata Sonik from the government of Maharashtra. Sujata ji, why don't you please introduce yourself?
Hello, Priya, Jerry, and all the honorable parliamentarians who have joined this webinar. My name is Sujata Sonik. I'm a civil servant from the state of Maharashtra in India. I have been working the last 10 years in the three important fields of health, public health, climate change and disaster management, and finance. And I'm very happy to join you all today.
Thank you. And I do believe Honorable Kalila is also with us now. May I please invite Honorable Kalila to please introduce herself to this plenary panel session.
Thank you very much. Can everyone hear me?
Yes.
Yes.
Okay, so thank you very much. My name is Honorable Dr. Christopher Kalila. I am a member of parliament in the Republic of Zambia. I'm a member of parliament for 10 years now, and I'm also the chairperson of the Health Committee, as well as the chairperson of the National Working Group on Sexual and Reproductive Health, which is a project under the Southern Africa Development Coordinating Committee, also known as SADC. And I'm also a member of the Global Parliamentary Alliance. I am very happy to be invited and to participate in this very important webinar, and I look forward to learning a lot and listening to various colleagues who are participating in this forum. Thank you.
Thank you very much. So the floor is over to you, Neil and Caroline, and you can please go ahead and take it forward.
Okay, thank you, Priya. First of all, welcome to everyone. Welcome, dear honorable members of parliament and dear colleagues. I'm delighted to welcome you to this parliamentary dialogue on the future of health systems. This is the second webinar that we are organizing as the Global Parliamentary Alliance for Health and Development. I'd like to hope that you're all doing very well given these very specific circumstances, and especially that your families, your teams, and your loved ones are all very healthy as well. That they mute themselves unless they are a designated speaker in this session, and like this we can avoid a bit of background noise. So first I'll start I'll be moderating this part of the webinar, and I'll first start with a bit of technical information about how we will structure the webinar, and then I'll provide a bit of introductory information about the subject of the webinar. Then we'll go to our speakers. So first, we have over 20 members of parliament who have signed up as participants on this webinar, and this webinar will last 90 minutes, so we will end on time. So I'd like to ask all speakers to make sure that you stick to your allotted time. We're all experts in webinars by now, and so you know that you lose your audience if you speak a bit too much. So we want to make sure that the important information that we all have to convey is well absorbed. Then we'll be dividing this webinar into 5 distinct parts. So first we'll be hearing from the Honorable Marie-Rose Nguyefa, who is a member of the Advisory Council of the GPA and President of the Forum of African Parliamentarians on Population and Development. And then we will be hearing from our thematic experts. So we'll be hearing from Dr. Priya Balasubramaniam, as well as Dr. Phyllis Awor and Dr. Jerry Bloom, who will reflect the Unlocking Private Enterprise for Public Good and Learning series by the working group that they're a member of. And then we will go to WHO, who will have a presentation. We will hear from David Clark, who is the team leader of Universal Health Coverage and Health Systems Law from the World Health Organization. Then we will move on to the parliamentary panel. And so there on the parliamentary panel, we will hear short interventions from the Honorables Enver Roshi of Albania, the Honorable Esther Passaris of Kenya, and the Honorable Chris Kalila of Zambia. At this point, I also want to note and recognize and appreciate all the members of parliament that we have on this call with us. The last list I was given is that we had honorable parliamentarians from Gambia, Ghana, Kenya, Lesotho, Malawi, Sierra Leone, Zambia, and Zimbabwe in attendance. So greetings to all of you. After we hear from the parliamentarians, then I will hand over the moderation to my colleague Priya, who will then introduce the next round of 3 speakers, who are Sujata Sunik of the government of Maharashtra in India, Dr. Suzanne Weisbecker, who is the global head of access to medicines at Takeda, and then Ms. Lola Ngong from Amref Health Africa. So for all the parliamentarians who've signed up to participate in this webinar, and for those who are interested to speak, please raise your hands in the plenary session, and so that we can address your questions during the panel discussions. And so there's a little button that you can press somewhere on your screen where you can express how you want to raise your hand. Before turning the floor over to our speakers, I'll now provide a short introduction as to why this parliamentary dialogue on future health systems is so important today. So first, universal health coverage, UHC, is fundamental for achieving the Sustainable Development Goals related not only to health and well-being, but also to ensure quality education and to achieve gender equality and women's empowerment. Also, 1 year ago, in September 2019, a landmark political declaration on UHC was adopted by all heads of state and governments in New York at the United Nations. Dr. Tedros, from the Director General of WHO, reminded the world that we only had 11 years to make good on its Sustainable Development Goals, and that universal health coverage is key to ensuring that that happens. Today, as we mark the first anniversary of this landmark declaration, I would like to remind us that universal health coverage and the advancement of primary health care is a political choice, and one that we have to make to protect and advance sexual and reproductive health and rights and gender equality. The current COVID-19 pandemic have brought devastating social and economic consequences and have demonstrated the importance of appropriately investing in UHC. It also became clear that UHC will remain elusive for women and adolescents unless it includes sexual and reproductive health and rights. it is important to stress the key role of parliamentarians in reforming and strengthening health systems and ensuring that UHC works and making sure that the health and rights of their citizens and electorates are upheld. One of the key tasks to ensure the relationship between public and private sectors are well guided by MPs. MPs have a key role to play in addressing emerging gaps in legislation, regulation, policy, oversight, and accountability, and to monitor public-private partnerships so that it can benefit future generations and bring them closer to state and to the state of complete physical, mental, social well-being in all matters related to the reproductive systems. So finally, members of parliament have a key role to play in addressing emerging gaps in legislation, and it is with this statement that I'd like to first welcome a parliamentarian as our first speaker, and that is the Honorable Marie-Rose Nguyefa, who, as I've said before, is President of the Forum of African Parliamentarians on Population and Development, and one of the members of the Advisory Council of the Global Parliamentary Alliance on Health, Rights and Development. So, Honorable Marie-Rose, the floor is yours for a few minutes. Marie-Rose, Honorable Marie-Rose. Honorable Marie-Rose?
Yes. Did you hear me? I'm on the floor.
Okay.
Hello?
Now we can hear you. So we can hear your statement.
Okay, thank you. Thank you, O'Neill. Thank you, all the members of Parliament, honorable member. I'm very glad to participate with you in this session. On behalf of the parliamentarian champions of population and development across the globe, I welcome you to this parliamentarian dialogue. 1 year ago, in September, all the heads of state and government met at the 74th United Nations General Assembly. They made the political declaration of universal health because they recognize the importance of moving together to build a healthier world. Today, also recall the Inter-Parliamentarian Union Declaration of USC made in 2019. All parliamentarians represented here today affirm that our political commitment is to work toward ensure health is human right that need to be enjoyed by all the people, by all our constituents. This morning, as we deliberated on the unlocked private enterprise for health, I wish to state that parliamentarians fully recognize that the private sector has a large and growing role in health systems, especially in low-income and middle-income countries. We welcome the dialogue with researchers and experts and look forward to considering new perspectives that will contribute to be performance and to the health of the health system. And a whole, we look forward to other legislative reviews that can enhance working for both the public and the private sectors. The contribution of researchers is essential. We need clear and constant communication between researchers and policy makers to enable us strengthening the case of the public-private sector mixed. We need to have the best practice that demonstrate this mix is key in ensuring affordable timely and be eager to find new ways that can meet the need of our constituents, particularly in areas in maternal health, adolescent health, and gender equality. Today, we will get to excuse me for the name, Enver and various needs and risks in working more closely. In the second, you will honor Esther Passaris from Kenya on measures that government can take to ensure that the private men of the universal health coverage and particular gender equality. And last, the third one, but not the least, Honorable Dr. Kalila from Zambia will share on the kind of evidence parliamentarians need to advance support policy and oversight emergency public-private partnership. The floor is yours. Thank you.
Thank you very much, Honorable Marie-Rose. Thank you for those opening words. I'll now go straight to the technical bench and would like to welcome the three representatives of the private sector and health thematic working group. So I'll start with Dr. Priya Balasubramaniam of the Public Health Foundation of India. So Dr. Balasubramaniam, the floor is yours for 7 minutes, I believe, and then we'll hear from the other two speakers.
Good morning, honorable parliamentarians and respected attendees, and thank you, Neil, for the kind introduction. On behalf of the private sector and health thematic working group, we'd like to thank the European Parliamentary Forum for giving us this opportunity to both collaborate and share some of the findings from our ongoing mutual learning series on redesigning health systems for universal health coverage, managing new kinds of health partnerships during and beyond COVID-19. I would like to go ahead and share my screen now. So Remy, would you please give me permission to be able to do so? No, I still need your permission to be able to share my screen. Great, I hope everybody can see the screen clearly. Okay, great. So I'd like to start with a brief introduction of who we are. We're a group of health systems researchers from various institutions from the global north as well as the south, who've been focusing on better understanding the role and diversity of the private sector. We're especially interested in how and what kind of evidence is needed to better engage the private sector and governments for both health system redesign as well as to build capacity for universal health coverage. How do we do this? We help to contribute to new thinking about the performance of mixed health systems and all the actors that are in it. We help build new partnerships for research and learning. And we also convene meetings such as this to be able to share evidence. So what is the mutual learning series all about, and how do you think it might be able to contribute to you as parliamentarians to build capacity on better understanding non-state actors in health? So the mutual learning series workshops are really a short series of digital roundtables that explored how governments as well as the private sector were collaborating in response to COVID-19, and what are some of the lessons that we could learn from these collaborations that could be applied to build health systems capacity towards universal health coverage and towards a hopefully a post-pandemic world. So the three meetings actually explore three areas of health systems engagement. The first meeting explored new partnership models for health systems capacity and service delivery. The second meeting looked at the governance of the private sector in health systems and about better managing some of these emerging partnerships in relation to accountability and sustainability. And the third meeting, which is upcoming on the 23rd, will really unpack the role of evidence. It will bring together outputs of the first two, including this one, and examine the role of evidence in engaging public and private sector stakeholders. The objective of this mutual learning series and the eventual outcome was to really generate fresh ideas on how private sector health delivery and access can engage researchers to partner more effectively with both governments and public health mechanisms across populations and levels of care. The overall outcome that we're seeking to achieve is to create, hopefully, a collaborative platform for shared value creation and alignment through both evidence as well as opportunity between non-state actors and the government to be able to jointly identify health priorities for interventions, as well as to engage together to collaboratively strengthen country health systems. Why are we doing this? COVID-19 has changed the health sector landscape and has exposed several fault lines in country health systems across the world. This is not just for highly developed systems in the north, but as well as emerging economies in the south. There have been a variety of providers in terms of ownership and relationship to governance and regulatory systems when engaging in COVID-19 response. There is a need to, more than ever before, to ensure access to an affordable mix of preventive and curative services to reduce dangerous or exploitative practices by bringing in some types of non-state actors. Yet, in all this responsiveness, there's often very little clarity on the various mechanisms of engagement between the private sector and the state, and that is what we're hoping to unpack as a result of the series. So, what are some of the findings from the meetings of June and July, and which really dwelt on a diversity of actors and stakeholders from the private sector, government, civil society, and academia, who came together to discuss essentially new directions for public-private engagement. One of the key consensus for all these different stakeholders was that strategies for making rapid progress towards UHC eventually need to make use of all contributors to the health system. And some of the new health partnerships that have emerged offer opportunities across a range of areas. Firstly, they offer opportunities for change. So non-state actors have complemented public sector response to COVID-19 across many areas of the health system. So it's included supply chains, service delivery, products, diagnostic services. And invariably, this is one pandemic that has provided unique opportunity for joint public and private engagement to collaboratively strengthen health systems. So one is an opportunity for change. The second is the opportunity for innovation and recognizing innovation. So among all the public sector providers, digital technologies have especially demonstrated their potential to leapfrog health system weaknesses of fault lines. The outbreak has actually allowed the private sector to easily and often inexpensively share data with the government and its partners. However, there is a need to see how this can be better streamlined to make health data shareable and yet secure. There is a need and an opportunity to finally move beyond pilots and prototypes. For innovations that are local and to be championed at a local level and rolled out, barriers need to be addressed. And some of these barriers include the need to change regulatory and health systems, health information levels at the legislative level, new approaches to negotiating partnership contracts with the private sector, and effective measures to monitor performance in order to curtail predatory practices of some private health care providers, as we are seeing across the world today. It also emphasizes the need more than ever of the importance of governance and leadership, or government leadership. Governments more than ever need to clearly define their priorities and establish appropriate regulations and to build capacity to manage effective partnerships with the private sector. This includes to be able to collect and analyze data from the private sector and governance mechanisms to manage contracts and define partnership models with greater clarity. There is more than ever the need to build accountability and trust between two sectors. So in the absence of effective oversight frameworks, there are risks that can put both the public and the private sectors at jeopardy, and the risk that they will not perform well in being able to meet population needs. So to mitigate potential risks, some companies need to change the way they practice to allow them to become greater and stronger partners in a country's UHC strategy. Industry associations have volunteered to work with governments to create and establish monitoring and compliance mechanisms of norms and standards. Similarly, non-for-profit organizations can often provide a brokerage or a bridge between governments and for-profit sectors, as well as social enterprises. And finally, but most importantly, the need for enabling legislation. Appropriate laws need to encourage innovation, but also discourage dangerous or exploitative practices. However, regulatory cholesterol can slow down private sector innovation, and light touch regulatory mechanisms can help by being both non-prescriptive, but also to be able to aid rapid technology advancement. Finally, the role of research networks, and my colleague Jerry will talk a little bit more about that towards the end of this presentation. Research and research networks can play a valuable yet objective role in engaging stakeholders like yourselves, government as well as the private sector, in shaping ways in which both these sectors could work together with one another and towards a common objective for public good. I'll stop here, and I'd like to now move to present a regional example in engaging local private sector actors and providers in maternal and child health, which will be presented by my colleague, Dr. Phyllis Awar from Makerere University. Over to you, Phyllis.
Okay, thank you very much. As introduced, I'm from Makerere University at the School of Public Health, and I wanted to take one slide to just really write our university and let the African parliamentarians know a little bit more of who we are. So we are one of the leading universities and public health institutions in Africa, but our main responsibility has been to train health workers and to deliver health services and health service management. So these universities, we are mainly training health workers, but increasingly Makerere University and other African universities are playing a significant role in advising governments on evidence-informed policies. For example, the Universal Health Coverage Roadmap for Uganda has really been designed by our specialists at our School of Public Health, including myself, and our National Health Insurance Plans and Bill, which is in Parliament, was really designed or strongly contributed to by health systems and public health specialists. In terms of COVID-19, it's clear to all of us that the response to COVID-19 has been led by public health experts all around the world. And in Uganda and Africa as well. Priya, please proceed. Thank you. So I was asked to take an opportunity to present a clear example from my work, or our work, on how we have been directly supporting and contributing to evidence-based decision-making in Africa. And my work has focused on the role of the private health sector in improving access and quality of child health care. And I will talk towards the end about how we are partnering with governments and other development partners to do this. But we have been interested in the private sector because of huge public sector gaps or weaknesses in our health systems in low-income settings, and which are now not directly public owned, but there is a coexistence of public and private health providers who are working together in different ways to meet the health needs of our populations, specifically in Africa and South Asia. My work has focused on the role of retail medicine shops, drug shops, so a mini pharmacy in rural communities, and how these have worked to improve quality of care. Next slide, please. A drug shop like the one in the inset in that picture is an important source of care in Africa. Half of all patients with fever in the outpatient setting first get sick care at a level of a small pharmacy. And in terms of child health and even maternal health, specifically half of all children with fever seek care at the level of drug shop. There are two key problems with the healthcare that is provided at this level at the primary healthcare and the private sector, which are drug shops and small rural clinics, is that there is poor regulation of this group by governments or ministries of health, and there is poor quality of care. So next slide, please. For the last 10 years, my research group and myself at the School of Public Health have really worked to test different ways to improve quality of care in the primary healthcare private sector. So among us private providers in small drug shops and clinics, we've studied how to improve the technical competence of these providers and the safety of care that they provide, and the effectiveness. I mean, how well do they stick to protocols and treatment guidelines, and also issues around cost that is, of care provision and cost effectiveness. And in terms of equity, how what proportion of poor people or rich people seek care in the primary healthcare level at rural clinics and drug shops. And really, what is the overall contribution in terms of access to healthcare from this private sector? Next slide. And so, next slide, Priya, please. So we've worked from district level small pilots. Just, yes. This slide is showing the just a bit of a snapshot of some of the evidence that we have generated from district level pilots in terms of how can quality of care be improved in the primary healthcare setting in the private sector, into regional level, and then now we went ahead to collect the literature, systematic reviews on quality of care or access to care and care provision in the private sector. And finally, we are writing global level documents on how to deliver child health interventions through the private sector. Over the last 1 year and for the next 1.5 years, we have partnered with some international agencies. This is UNICEF, UNDP, and a program in WHO's office, Special Program for Research and Training on Tropical Diseases, with some governments, with an aim to catalyze systematic engagement of private frontline service providers to deliver quality child health services. And we will focus initially in 2 countries. These are Tanzania and India, where we are performing country situation assessments on the private sector utilization, as well as, and then writing technical notes, taking notes to government and to the development agencies on how they will engage better. In addition, we are engaging stakeholders in a purpose-oriented dialogue like this parliamentary forum, dialogue on public-private partnerships. And for me, I have a specific question that we will take forward in the discussion is how useful would it be for us to communicate with this parliamentary forum and share our evidence briefs and system analysis? And would other parliamentarians be interested in learning more about the work over the next 1 year and engaging with us? And that's the end of my presentation, which is really an overview of how we've gone from zero small pilots, bigger, and how we are working now at national and global levels. And so I'd like to now invite my colleague, Dr. Gerald Bloom, to really summarize how we are working in this thematic working group, and also how we would like to take forward our engagement with this parliamentary forum. Over
we
to
seem
you.
to have missed one slide there. But
yeah.
Is it there?
Doesn't
No,
look.
okay, it's okay. Okay, as Priya mentioned, we are establishing a platform for mutual learning. And I thought I'd say a couple words about why. I think what Phyllis demonstrated is how researchers can work with a number of stakeholders around learning how to make a mixed health system work well. The point is there are no blueprints for managing a mixed health system. That means that governments, private providers, associations of providers and users of services Parliamentarians and others need to define their own roles and responsibilities and learn how to carry them out effectively. It's important to test new approaches and document what works, what does not work well, and why. And it's also important, as has been mentioned, to monitor for undesirable outcomes, to prevent problems as they emerge. And we need mechanisms to ensure learning at national level, as you saw with child health, but on other problems, and provide mechanisms for exchange between countries so that every country doesn't have to learn by itself. We want to explore with you how such a platform could help you address your responsibilities. And put a couple thoughts, but it'd be good to get yours. Well, first, it provides access to evidence on health system performance, as we saw with child health. But it also enables informal exchanges of ideas and experience with both public and private sector and across countries. So a forum for informal exchanges. And it creates opportunities to look ahead and anticipate the impact of new technologies and changing markets, particularly by learning between countries. So in terms of this, I hope that your discussion can address some of the following questions. What are the potential benefits and risks for governments of working more closely with the private sector? It'd be good to identify both what could work well, but what are the things you're concerned about? Then what are the key measures that governments can take to ensure that the private sector contributes to progress towards UHC? How do you set priorities? What kind of evidence and advice can researchers provide you to help you provide your oversight role? And finally, how can a platform for research and mutual learning on the management of mixed health systems support the work of parliamentarians? What advice do you have for us about how to make it more useful to you? I think it's a big agenda and I look forward to the discussion. Thank you.
Thank you very much, Jerry, and thank you, Neil. So this concludes our presentation, and we'd like to hand over the floor to you again. Thank you.
Thank you very much, Priya, and thank you to all three panelists for a very rich presentation. I think that provided a great deal of food for thought. Now I'll turn over directly to David Clark, team leader for Universal Health Coverage and Health Systems Law at the World Health Organization, who will have a keynote speech and presentation, which will be within 10 minutes. So David Clark, the floor is over to you.
I'm just struggling to share my screen. It's saying that another participant is already, oh, thank you, that's great. Thanks everybody for the opportunity to speak today. Just to give you a little bit of context for my role at WHO, as well as working on the private sector topic, I do work a lot with parliamentarians and specifically with the Interparliamentary Union. So it's very timely that we have this opportunity to have this discussion today. We've been speaking with the IPU for a long time about universal health coverage, and we are certainly part of the efforts for the IPU, which led to the IPU resolution on UHC last year. I've also been speaking to the IPU as part of WHO's efforts to support countries with work on the pandemic. So what I wanted to talk to you about today is a few things. First of all, I wanted to talk a little bit more about private sector engagement and the whole topic. This is one of these terms which is used in quite different ways by different people, and I just wanted to very quickly hone in on what we mean by private sector engagement. I'll talk a little bit about what the COVID situation has shown in relation to private sector engagement, what our experience has been with working with member states. I want to talk a bit about the WHO roadmap strategy for private sector engagement. We've been working on this topic for a couple of years now, and we've come up with a strategic approach for private sector engagement going forwards. And I'm really interested in talking to parliamentarians about how we can work to support the effective governance of mixed health systems. We're already heavily engaged in conversations with researchers about their role in this important area, and would like to extend that to our parliamentary colleagues as well. So just very quickly talking about what we mean for WHO by private sector engagement. What we are focused on is, and this goes back to the World Health Report 2000 and the recommendations in that report, is the importance that governments focus on the governance of the whole health system, not just the public aspects, but the private aspects as well. And we think this is critical to ensure that governments can reach their health goals, including universal health coverage. If we can assure quality financial protection and equitable access to health services if we don't work with the private sector. So this has led us to this work on the strategy that I'm going to briefly talk about, and it's led us to work constructively with our member states as part of their efforts in relation to the COVID response. Key domains of engagement are on this slide. I'll share these slides so everybody can have a good look at them post the seminar. So we think there's a lot of work to be done in these different domains. There's certainly very important work to be done in relation to dialogue between public and private sectors and policy discussions. And that was something that Priya mentioned in her talk. We also think it's very important that we do better with the flow of information, not just from the private sector to the public, but also from the public to the private. It's very, very important that we have a different way of approaching the flow of information. And also, as has been discussed by the previous speakers, we really need to have a good regulatory framework for the private health sector, a smart regulatory framework, not one that doesn't do the job, and not one which creates unnecessarily red tape. We also need to look, I think, at the funding and purchasing arrangements for private providers. What we found as a result of the COVID situation is that many countries are really struggling with their purchasing arrangements for the private sector because many of them haven't got any experience in working this topic. And we also need to think about the whole mix of services and health systems, because the way the public sector operates can have a big impact on the private sector as well. Why is this important? Because as we've discussed in the previous discussions and speakers, the private sector is just so prevalent. If you look at, this is a study that WHO did last year to look at the private sector in different countries. And we found that in most WHO regions, the private sector provides almost half the care. And it's not just the rich that are going to the private sector, the poorest quintiles are also going to the private sector for their care. So it's not a question of whether we work with the private sector, it's how we do it, and how we work with the private sector constructively to ensure that countries can meet their health goals. The whole COVID situation triggered an urgent response in relation to this topic. One of the first things that we did was to do a call for action for mobilizing the private sector as part of the response. Dr. Tedros talked about the importance of a whole of society response to COVID. And so we started off with some work in this area, and we published very early on an action plan for working with the private sector to support the work of our member states. And what we've discovered as part of this whole terrible situation is that the COVID situation has really highlighted massive governance problems in many health systems when it comes to working with the private sector. So we think in line with our colleagues from the research community that it also provides an important opportunity to learn from these gaps and to strengthen the relationship between public authorities and private health providers. So what we've been thinking about in relation to the response is how we can actually support governments to get the job done in relation to responding to COVID. So we're not engaging with the private sector for the sake of it. We're encouraging engagement with the private sector to strengthen essential public health measures, facilitate effective treatment, maintain stocks of essential materials, ensure health workers have access to protective equipment, and protect the most important people in communities. And we have seen, as I think Priya said, a proliferation of private sector engagement across countries. Particularly in the OECD countries, very early on, they acted very quickly to bring the private sector into a response. And we're also seeing over time the same happening in a lot of other countries. But what we've also seen is that the countries who have responded positively and seem to have had the best impact in relation to bringing the private sector into the response have existing governance arrangements which take into account the private sector. The countries that don't have existing governance arrangements, and don't have existing experience of working in the private sector have struggled. And we also note, we're also not blind to the problems. We note that there have been some serious problems in relation to the private sector's activities in relation to COVID. This is about an article that appeared in about the situation in India, where it seems that in some places the COVID pandemic is leading to a massive distortion in prices and increases prices and threatening people's ability to pay for their healthcare. Very early on in the piece, we did some work with our member states. We did some surveys and some key informed interviews to better understand what was going on. And we found across the board. But many countries were uncertain about how to include the private sector in response. So we think that the research agenda around this is really important. We also noticed that there was real problems with planning. There are critical data gaps about the private sector in many countries. Some governments have very, very patchy information about the private sector in their countries and its activities. Often the private sector also said to us that it lacked the inputs it needed to play a role as an effective partner. We also noted in a few places that when countries were passing COVID emergency legislation, unfortunately there were unanticipated consequences, and they actually limited the private sector's ability to participate in response. We also have seen very big issues in relation to countries being uncertain about whether to reimburse the private sector or even to allow the private sector to operate in some cases, which has led to the situation in many countries where the private sector might fail. And this is a concern to us, because if it does fail, and it fails in a country where the private sector are providing all the health services, then it will have flow-on effects, not just in relation to the COVID response, but also in relation to the provision of health services post-COVID. So what this all highlighted for WHO is the need for us to accelerate work on our long-term strategy for the private sector, and how we would support governments and parliaments and the research community in relation to this important topic. So we have been working, as I said, for a little while now on this important strategy. We've come up with this theory of change, which very much focuses on the need to respect the fact that the private sector is quite different in many different countries, and that we do need to have an approach to private sector engagement which takes that into account. As Jerry well said, there isn't one blueprint for working in private sector engagement. You have to be adaptive. We think that countries need to change the way in which they behave in relation to certain key governance tasks. We think this is really important. The private sector topic is not a new topic in health. It's been around for a long time. But what we think needs to happen this time is for there to be real behavioural change in relation to how we work with the private sector around these 6 governance behaviours which are on this slide, which are about enabling stakeholders, building and nurturing trust, which is often mentioned as a problem with private sector engagement, delivering on government strategy, aligning the structures that are needed to enable effective private sector engagement and effective management of mixed health systems, better fostering relations, and building understanding across the board around this topic, because there's a lot of misunderstanding around private sector engagement and a lot of uncertainty about what it means in practice in different countries. Again, a very important area for the research community to look at. I'm not going to go into great detail here because I want to keep this short, but we have a results framework which we've developed for our work in this area, and we'll share this, and we'll also share the strategy document, which is just about to be published. But what I did want to share is this slide, which is about what we're thinking about doing in relation to taking this work forward, based on the priorities that we have identified by working with an expert group on what WHO should be doing in this area. So first and foremost, we think there's still a big problem in relation to political will for working in private sector engagement. While some countries have definitely wholeheartedly taken on board the importance of working with the private sector, there's still a lot of barriers in some countries who don't want to work with the private sector and think they should focus just on the public sector. And we just don't think that's tenable anymore. So one of the things that we're doing in relation to working with parliamentarians is we're going to set up a working group on the private sector within the UHC 2030 platform, which allows us to bring in participation from countries, from researchers, and also from parliamentarians. And we're looking at the moment about how we can bring the Interparliamentary Union into that network, but we can certainly look at how we can also bring other parliamentary groups into that network as well. The other things that we're doing in the short term is we're trying to increase knowledge of this topic. And some of you may have heard of the WHO Academy, which is a new training platform in relation to different health system aspects. And we're certainly looking at trying to produce some materials to be included in that Academy platform, which will be available not just to WHO staff, but to country Ministry of Health staff, but also to other people working in countries, who are interested in this topic and better understanding how it all works in practice. We're also thinking about whether we need to have a new WHO resolution on private sector governance. There is an existing WHO resolution on this, but we're thinking we might need to refresh it. And we would certainly welcome discussions about what role parliaments should have in relation to that. In relation to our work in the short term, we're also looking at this whole question of financial sustainability in relation to the private sector. As I mentioned in one of my previous slides, there are some big problems with the private sector facing significant financial hardship because they simply can't operate in relation to the COVID situation. And we're looking at whether that matters and whether or not government should be looking at investing in the private sector and what those investment criteria might be, particularly where private sector actors are providing essential health services, and the consequences of them failing are very serious indeed. We also very much focused on this whole area of data and accountability, just as the previous speakers mentioned. To us, it's a very important area, so we're doing some work in relation to data and accountability and digital governance. And we're very much interested in learning from parliamentarians about what they need to perform their parliamentary functions. Obviously, one of the very important roles of parliamentarians is to hold the executive to the account. And we'd be very interested to know what parliamentarians' information needs are in this space. And we also want to support learning and technical guidance with our colleagues in the research community. So we're very much working with the Health System Global Private Sector Working Group on this topic to look at what smart regulation looks like for this topic area in particular. And we're really, as Jerry said, we're really interested in parliamentarians' needs as well. And we're interested in how we can all work together in relation to this important topic. I'm going to stop there because I'm very conscious of time and need to facilitate discussion amongst all of the speakers and participants. But I'm very happy to provide far more detailed information about what WHO are doing, because it is a very complicated area and we have done quite a lot. And I'm very happy to share that information with you all. Thanks very much for the opportunity to speak today.
Thank you very much, David. That was a very strong presentation. And if I'm if I'm not mistaken, you've mentioned that you will share the presentation with all of us. So like this, everyone is able to go into a great deal more detail than the 10-12 minutes that was allotted to you on this webinar. So thank you very much. Now, for the next part, we will hear from 3 members of parliament, short, powerful statements based on what they've heard. And so we'll start with the Honorable Enver Roshi from Albania. So we will turn to you for 1 or 2 minutes, and then we'll go to the next 2. Honorable Roshi. You need to unmute yourself. You must unmute yourself.
Okay.
Yes.
Thank you. Thank you, Mr. Neil. As I told, I'm very happy to participate in this international conference to speak about the parliamentary dialogue on future health systems. As you know, the goal of universal coverage is to ensure that all people obtain the health services they need with suffering financial hardship when paying for them. There are many connections between this goal and the state's legal obligation to realize the human right health. The private sector has a large and growing role in health system in low and middle income countries. We have learned from the management of COVID-19 that sustainable public-private sector mix is what we need to realize better health system. Although I remind as honorable member that transforming our future health systems and achieving sexual reproductive health and rights for all needs us to pay attention to SDG 17, SDGs 17 calls for cooperation, collaboration, and partnership between government, civil society, and business. Our research has shown that in many developing countries, when people first seek diagnosis and treatment for an illness, they visit a private pharmacist, nurse, midwife, doctor, and drug seller, and traditional practitioner. People use these private sector providers, PCP, because they are often near, open for longer hours, and are seen as more considerate and sometimes less expensive than public sector counterparts. There is a lot of discussion on what precisely this sector can contribute given the varying function it can perform, the grassroots in the villages to the most contemporary technology system. Let me now address the following question. What are the possibility, benefits, and risks for government in working more closely with the private sector? When we look at the benefits of working with the private sector, we can agree that there tends to be high quality facility and infrastructure, competent staff and user satisfaction, and use of innovative technology which makes services delivery more efficient. However, there are risks of privatization. Cost of services is a major barrier. Existing governance and regulatory arrangements are not designed to effectively manage and coordinate mixed health systems. Legislation, policy, and oversight for managing the public sector are clear, but this is not the case for the private sector. This gap challenges and threats the universal health coverage objective and equality. Abuse of market power, for example, monopolistic behavior and predatory pricing is a major risk, especially for women and girls who need to access essential SRHR services. A public policy vacuum exists regarding the private sector and universal health coverage. And as a parliamentarian, we recommend that the best practice models be documented to enable us a champion for improved public and private partnership through legislative regulatory means. This will be crucial to ensure that countries make progress for the people's health. Thank you very much.
Thank you very much, Honorable Roshi. That was very interesting. We'll now go straight to Honorable Dr. Kalila from Zambia, and he will provide his example. Honorable Kalila. Honorable Kalila. You need to unmute yourself. Yeah.
Yes. Sorry. Yeah. Sorry, Neil, that I didn't get you. There was something wrong with my.
Okay.
I'm saying sorry, I didn't get you.
Yes. We now come to your short comments, if you have any.
Well, definitely I have some. My comments are based on the kind of evidence that we parliamentarians need to generate from the private sector in order for us to fit in with our overall work. As you know, as members of parliament, we're involved in an accountability framework that revolves around legislation, that revolves around representing our people, that revolves around allocating resources to our national budgets for health in order to support our health systems. And we have all seen this year the effect of COVID-19 and how the private sector has responded, how they have come in to help their governments. We have seen them provide money. We have seen them, particularly here in Zambia, participate, including in the preparation of temporary hospitals. We have seen them participate in the provision of PPEs and so on and so forth. What this means is that definitely the health systems of the future, we need to redesign them by including the participation of the private sector. In other words, I agree with everything that I've listened to here, that the private sector is important. It is going to continue to be important. But for us as members of parliament, we need to legislate, we need to allocate resources, we need to to hold the private sector to account for some of the things that, how we want them to participate in the health system. The question therefore is that in order for them to participate, we need some kind of evidence that is going to design our laws. Now, how do we generate that kind of evidence, and what kind of evidence that we need? Obviously, as parliamentarians, we are politicians. We are not experts in generating this evidence. We are not experts in getting data. So we have to depend largely on research institutions, such as I have noted, who are present here. We need obviously public health experts in government. We need the role of the academia, and we need various other stakeholders. We need engagement with these groups in order to generate that kind of data and evidence that we need as parliamentarians to be able to monitor and track progress of the private sector in order to make sure that as parliamentarians, we push our governments to achieve universal health coverage. And so then, what kind of data and evidence that we need? First of all, particularly in poor and third world countries, like speaking for my country, we need baseline information, first of all, to determine the size of the private sector. Who are the players? What kind of players? How big are they? That is basically at the rudimentary level. As parliamentarians, we need that information. And also we need information from the supply side. What kind of services are available? How affordable are they? How adequate are they? How appropriate are they? Are they of good quality? We need that kind of information because ultimately we need the best for our people in public health. And that we're going to rely obviously on research institutions, academia, and other people. But also on the demand side, we also need information so that all this information can go into the monitoring and accountability framework, that all this information can go into legislation. So on the demand side, we also need to know the health-seeking behavior of our people, their cultural beliefs. We need to sensitize them. We need to know several other information. So you can't make good laws unless you have data. You can't make good laws unless you have evidence, and this evidence which I've shared can only come when you engage with various other players. And when you have this, then you can make them into your laws, you can make them into your policy frameworks, you can make them into your accountability frameworks. And therefore, as members of parliament, you then can use that to monitor performance, to track performance, and to see whether the private sector is conforming to some of the laws or to the regulations that you have made. You also need laws actually to encourage them to begin to participate in your health system, because if you don't have laws that incentivize them, laws that provide money or that provide credit to them, then you will not have them. I mean, I agree with one of the early speakers, by the way. I think somebody from India who said that, yes, we need to regulate them, but we shouldn't over-regulate them also, because when we do that, sometimes then they begin to fall by the wayside. So I want to thank you for allowing me to participate. These are some of my comments on this matter, Mr. Deta, and all my colleagues that are here. I hope they have provided some insight to the discussion. Thank you.
Thank you very much, Honorable Kalila. That was very interesting. And now we'll go straight to the Honorable Esther Passaris from Kenya. A few words from you.
Thank you. First of all, I want to say thank you very much for convening this parliamentary dialogue. And I want to say thank you to all the members and all the presenters so far. I mean, Kenya has universal health as one of its 4 pillars that the president wants to attain. And I think we've seen so many steps being taken by the country in terms of ensuring that our constitution, you know, Article 43(1) of our constitution actually gives the right of health to all citizens, including the highest standard. Now, you know, I want to give you some examples of what I've encountered since I became a member of parliament that made me realize that, one, private sector is important. Mission hospitals are also very important. We've got a lot of mission hospitals in this country, and government has to, much as it has its agenda in terms of improving its infrastructure, what Kenya did is they came up with a medical equipment supplies project where they were trying to give supply all the hospitals with sufficient medical equipment in terms of scanners, MRI machines, all the diagnostic equipment. But of course, there was a failure in the sense that we provided this equipment. Some places didn't have the infrastructure to take them. Some places they didn't have enough technicians. So as a country, I think, you know, we have to involve the private sector, but also the public hospitals have also got to get their act together. With COVID, we saw that we didn't have, all of a sudden there was a panic. We didn't have enough ICU beds across the country. we realized that if we had a crisis with COVID, and thank God that Africa somehow has managed not to have such a high impact. I mean, listening to UK having 3,000 dead just about 2 days ago, I mean, Africa and Kenya has not had that kind of magnitude of dead. We've got a lot of asymptomatic. And had we had that situation, it would have been catastrophic for Kenya and most of the African countries. We have to, as a continent, I think, much as we want to have the private sector lifted up, we also have to ensure that the public sector gets its act together and gets efficient. Now, I'll give you an example. We have the National Hospital Insurance Cover. The National Hospital Insurance Cover gives every Kenyan the right to get medical attention in a public institution. And in some private institutions that are licensed by the government to ensure that the gap is bridged. But unfortunately, it only pays when you're in hospital. So if you're a person with cancer or a person with diabetes, you have to buy medicines from very, very expensive institutions. Right now, we've got a lot of scandals with our medical supply unit, KEMSA. And of course, that has also made donors become jittery. And it also means that the impact of donors withdrawing funds will be, again, a collapse in provision of medical drugs, pharmaceutical drugs available to the people. But I think we've got India. India has somehow managed to get the public and the private sector to both work on more or less the same level. I was in India and I saw that in the hospital, even though it's a private hospital catering for medical tourism, they also were catering for the poor within the vicinity, and the drugs were so cheap. Now, we have the mission hospitals. I remember one asking us, please buy us an ambulance, the mission hospital, please give us some medical staff to help us out. And we're saying, no, you're on your own. But what we fail to understand is the missionaries, the donors are providing the money to put this infrastructure, but we as a government cannot disconnect. Now, having AMREF here, and AMREF, I know the CEO of AMREF sits on the Africa board of Universal Healthcare. I think there has to be complete dialogue. We've got all these studies, but every country has its unique problems. If we can somehow ensure that government recognizes that private hospitals, there are private hospitals providing for the rich, yes, but there are many, many private hospitals providing the gaps. And we have that even in our schools. We've got public schools and then we've got community-based schools. Now, in the community-based schools where all our children go, we're not able to provide for them teachers, books, food, the things that we provide in the public schools, sanitary towels, and when it comes to reproductive health rights, we say it is a right for every Kenyan to have reproductive health rights. But again, we have the part of the constitution that talks about abortion, and then we take the whole reproductive health right and bundle it as an abortion issue, and then we fail to provide our young mothers and citizens the protection and the help that they require. So I believe that it is so crucial that government engages in its universal healthcare programs with the public sector, the mission hospitals, and the private sector. And in all, ensuring that it doesn't paralyze private sectors, because right now private sectors are paralyzed because government has not remitted the money that it owes them for the services they've already provided. So there needs to be a clear framework on how this whole agenda of universal healthcare with every partner, and Agenda 17, SDG 17 is about bringing partners together. We cannot achieve universal healthcare without all hands on deck. And then we also have to ensure that we look at India. I mean, India has got a success story. Private and public, and medical is affordable, drugs are affordable. It is such a shame that somebody who is really, really marginalized has to buy the basic drug the same price as I'm buying it. There has to be community pharmacies that are offering these drugs at a really affordable rate. I know the Indian government gave us a donation of 3 containers of drugs, which we never even collected. So again, coordination on how we work together with our various players. We've got a lot of work to do. COVID has taken us back in terms of where we were when we started. And we've lost a lot of momentum, especially in reproductive health rights. We've seen a lot of women have been abused, defiled, and the impact of COVID and reproductive health rights is not going to be seen now. It's going to be seen in another 4 or 5 months. Domestic violence, mental health. So when it comes to health, we've got a lot of work. I mean, that's the basic thing that you have to provide for your people. And I think that this dialogue is so important. How do we take it next to make sure that we actually look at how nothing else suffers in a pandemic? Because I'll tell you, HIV/AIDS has taken the back window, polio, all these other things. Everybody was just COVID, COVID, COVID. And now just think, how many people didn't go to hospital that didn't have actually gone even worse? It's a collapse. It's a collapse in a pandemic. But the fact that we're having this discussion shows that it is important to make sure that everybody comes on board. And government cannot achieve universal healthcare without the private sector, without the mission hospitals, without affordable drugs, without reproductive health right laws that are respected. We have to stop this whole idea of religion impacting reproductive health rights of citizens. And I feel that, Neil, honestly, thank you so much for this opportunity to share the experiences here. But I think Africa, the impact of COVID might not have been death in Africa because we were asymptomatic, but the impact of COVID to Africa will be how back we moved in terms of universal healthcare and in terms of ensuring that the gains of the SDGs are not lost. I think our impact will be so much more negative in the future because we're not going to be able to cope with it. Budgets, budgets, budgets. We need more money for healthcare, because, Africa requires that. The president has been going around opening hospitals. All the county governments have been trying to improve their ICU. So in that respect, we'll be fine. But in respect of ensuring that we've got the right support, like oncologists, we need more doctors that are specialized, for non-communicable health illnesses. So I think this dialogue is important, but the clear steps to ensure that government starts talking with all the players is crucial. Thank you.
Okay. Thank you very much, Honorable Pesaris. That was a very powerful and very engaging statement. Thank you very much. We're running low on time. From what I see, we only have about 20 minutes left. Now I hand over the floor to Priya, who will take us through the next session on reflecting on discussions. So Priya, the floor is yours, and it would be great if we can try to stick to our allotted time. Thanks very much. You need to unmute yourself, Priya.
Thank you, Neil. I'd like to now turn the conversation over to our discussants for today. We have three really exciting people offering very diverse perspective. For the benefit of those parliamentarians who joined later in the discussion, it's my pleasure to reintroduce them. So first we have, bringing in a policy perspective, we have Ms. Sujatha Sonik, who is the additional Chief Secretary in Skill and Entrepreneurship Department, the Government of Maharashtra. She's worked at the state level as Principal Secretary of Public Health and Financial Reform. Sujatha is at the forefront of COVID-19 management. She is working very closely with the private sector even as we speak, both in relation to digital providers as well as traditional for-profit as well as not-for-profit private sector. And Sujatha will bring in that perspective into reflecting on the conversations by the parliamentarians today. Offering a private sector perspective, we have with us Dr. Suzanne Weisbacher, the Global Head of Access to Medicines at Takeda. Dr. Weisbacher has been working for over 15 years in the healthcare and pharmaceutical industry with knowledge and experience in areas of access to medicines and emerging markets in both the Middle East as well as North Africa. And today she will bring into the perspective of the role of the private sector even as COVID-19 unfolds and in relation to access to medicines. And finally, bringing in a regional perspective of regional partners, we have Lolem Ngong, the Chief of Staff to the Group CEO of AmRef Health Africa. Lolem is a very seasoned global health as well as governance professional in global health diplomacy, as well as governance, and the use of strategic partnerships to address public health challenges. And she will bring in this, this perspective to kind of reflect on some of your comments. So without much ado, I'd like to invite Sujata ji to reflect on these conversations. In particular, I would like you to maybe reflect on what Honorable Pasaris has talked about how India has been able to manage the public-private dichotomy in relation to COVID-19 and address some of the examples from the Indian state on what kind of regulatory and government mechanisms that are actually being enabled to kind of create a more balanced public-private engagement that has long-term implications for health systems and UHC. Over to you, Sujata ji. I would request all speakers to keep their comments to about 2 minutes, please.
Thank you very much, Priya, and my compliments to all the speakers who spoke before me. I learned a lot from their comments. I just want to quote our Ghanaian diplomat and the 7th Secretary General of United Nations, Dr. Kofi Annan, when he mentioned that health will certainly be seen as not just a blessing to be wished for, but as a human right to be fought for. I think so many years later, this still holds true. He was from Ghana, and Ghana today is perhaps successfully launched the National Health Insurance Scheme, which is a key factor contributing towards the achievement of UHC in their country. There are so many other lovely examples from various African countries, and I feel in many ways India is not very different. We are having the same challenges as far as shortages of human resource are concerned, and all political leadership, elected parliamentarians face this issue of the increasing gap between the service and quality of health services that government provides for. There is an element of path dependency because in many of our systems, we are providing free health care, not to be confused with universal health coverage. And because it has been given once, there is a very little scope for rollback and bringing in user fees. These are the challenges that we face. In Maharashtra, also, we are facing the same situation. I would like to give 2 examples, one before COVID and then the other which we have been able to successfully implement during COVID. Before COVID, we ran a project called the Community Management of Acute Malnutrition, which was a fully sort of a stakeholder run project for 2 years, where in the tribal belt, we, in partnership with Tata Trust of Mumbai and UNICEF Mumbai, we ran a screening and feeding program for the acute malnourished children and their mothers in one of the tribal districts of Maharashtra. This is a documented study. It is a published work. The findings were brought out and shared with other government departments. This was a successful partnership. Now, the key ingredients of managing, government working with private sector, I think there are a couple of key issues. One is there has to be a detailed memorandum of understanding, very clearly defined roles that each entity plays. There has to be a non-disclosure agreement because you are sharing data. And more importantly, it's very important to fix the goalposts. What is it that you want to achieve together with them? We must also remember that private sector usually would work for profit, and government typically is working for public welfare. So an understanding about each other's restrictions and the limitations that come in because of our unique positions is also very important for a successful partnership. In view of this, during COVID in Maharashtra, we launched a series of technological interventions and apps such as monitoring and contact tracing solutions, IVR-based telemedicine solutions, testing and detection solutions, and mental wellness solutions, which was mentioned also by one of our esteemed speakers, by having a platform where we were constantly engaging with each other. Some of the solutions obviously cost money. So we set up a venture capitalist-led fund so that we could, provide some of these solutions initially pro bono to the user departments. And subsequently, we set in motion a system of engaging these private companies to come on board and help with the management of COVID-related disease management programs and scaling up of the capacity of the government and city and municipal hospitals. And that funding helped to seamlessly bring them on board. And we are now working on building digital health record systems as per the recent announcement of the Government of India for building a national digital health mission now. So these important partnerships helped us to overcome generally the issues that come up. And I would just like to end by giving a message to all our esteemed parliamentarians that the WHO model of UHC is quite well known. There is another model that has been written by esteemed faculty of the Harvard Chan School of Public Health. It is in that book called Getting Health Reform Right. And there are 5 key ingredients of how to manage building these kind of partnerships. That is financing, payment, organization, regulation, and behavior. Usually, this sector is highly political. The Immergut has written a whole theory on how the medical health personnel are an important voter group in any country's system. And for parliamentarians to be able to expertly handle and navigate this journey, it's important to be able to use any one of these 5 approaches to manage building capacity. At the end of the day, I would say that, we should give up this illusion that we all know what is best. We need to work together. Partnerships are key, and the private sector has a very important role to play, especially in view of the large pandemic that the whole globe is facing. And I will end my remarks with this. And thank you so much for giving me this opportunity.
Thank you very much, Sujata. That was really very insightful, and hopefully we'll have some more room for discussion. I'd like to now invite Suzanne to talk a little bit about what it is to be the private sector in the middle of all these discussions, and especially weigh on some of the comments made by Honorable Passaris with relation to access to medicines, and what, how has COVID re-engaged the ability to access medicines in terms of affordability and the kind of collateral damage that COVID is causing. How is the private sector being able to react to some of that? So it would be great to get some of your perspectives and the work that Takeda is doing in this regard. Over to you, Suzanne.
Dear Priya, thank you very much. Hello, everyone, dear honorable parliamentarians and colleagues. It's a pleasure to share the view of private sectors from a pharmaceutical company perspective. Yes, and indeed, Priya. So the current pandemic has amplified the need as well as I believe, the openness to strengthen the relationship between public and private partners. So, and we see and saw examples that we can move fast, that we can make changes, yet we also need to have a clear framework. So overall, when we look at the private sector with our expertise, we can really accelerate implementation, and we can follow the government if we get clear guidance, because the governments are best placed to lead and create the right environment and leadership for us for private sector engagement. So, and I'm grateful to see all the thoughts and hear the different views in terms of what is needed. And Honorable Passaris mentioned the clear framework in terms of how we can work together. Some more transparency is needed. So I think that we have currently a unique opportunity where there is a lot of dynamic and openness on both ends to really rethink how can public-private partnerships work and what is required to make them successful. For example, we have been developing under the local leadership and governmental leadership in Meru County in Kenya, what we call a blueprint with AMREF and many other partners. And I believe that's a great reference point for a successful public-private partnership, where we can and are driving significant and measurable impact. So we are generating the data, we can show what we are changing. And that initiative is building on a consortium of partners. And again, it's between the local government, the private sector, including NGOs, And we really made a difference. We trained more than 1,000 community health workers, screened more than 11,000 people, and received also access to treatment. Of course, due to COVID, and thanks Priya for mentioning that, we see there is a lot of collateral damage in terms of patients with NCDs not getting access to the treatment they very much need. So from a private sector, we can of course follow up or reach out to make sure that to help wherever possible in terms of distribution of the product. Yet there are also other barriers to access, for example, getting to the treatment centers, and treatment centers pretty much also quite focusing on COVID. So yes, we know we have so to say, a backlog. We need to catch up with patients on NCDs, and we probably, as mentioned before, will only see the impact, the negative impact of COVID on patients with NCDs over the next 6 to 12 months. So my parting word overall is that we as a private sector are eager to engage and do need transparency from governments on how you want us to support. We want to and must jointly foster greater collaboration, leveraging the strengths of both the public and the private sector, and to truly drive long-term impact and sustainable impact. And as we have seen successful examples during the pandemic, I believe we can take this unique opportunity, prove it to ourselves and the many patients in need that we can make a difference to them.
Thank you, Susan.
Thank you.
Actually, jumping off from what you had talked about, where, with regards to Takeda's work with AMREF, I'd like to segue to our next speaker, Lolem. And, one of the interesting things that I've seen is AMREF's ability to kind of act as a via media between working with the public sector as well as the private sector. Could you kind of reflect a little bit on how you have managed this kind of strategic partnerships? How have you evolved working together with a company like Takeda and the government of Kenya? What are the checks and balances that this kind of partnership has involved? And ultimately, what's the role of research or evidence in able to better capacitating or documenting some of these partnerships for parliamentarians?
Thank you, Priya. It's really an honor to be here and to be before parliamentarians, including my parliamentarian, Honorable Pesaris. So, when your parliamentarian is part of a discussion, I have to represent her well and not embarrass her. So I'll do my best. Really great discussion, and I've been taking notes and really trying to reflect on just some of the many points that have come up. And so, Priya, to your question, I think AMREF, we've really been able to serve as this intermediary between communities, and private sector and the government. A lot of it really stemming from, the history of AMREF and what we strive for. We want to be able to bring healthcare closer to communities. And I think that is what has really driven all of our various strategic partnerships. I had a different example to highlight on our partnership, but because, my parliamentarian brought up UHC, and I think in Kenya, for example, Kenya has really made great strides in advancing UHC. We're not there yet, but we're certainly on the path. And, when I think about, Priya, your slide, on one of your slides, you talked about all the various contributors to the health system. And just thinking of what Susan mentioned around private sector's eagerness to engage, to have transparency, to collaborate. When I think of those things and think about how AMREF has supported the government of Kenya's UHC agenda, there are a few things that come to mind. So where we started was to really look at what are those things that are needed for the government to effectively move on its UHC agenda, and to identify those needs. And luckily, some of those were areas where AMREF has a comparative advantage. And so we then started working with different private sector partners, working with foundations to also identify their role as an effective partner in delivering on the UHC agenda. So we have negotiated investments into the UHC agenda. We currently do provide technical assistance to the government, including secondments to the government, to really ensure that we are crafting and implementing universal health coverage, which makes sense for Kenya. You know, as somebody mentioned before, it's not a one size fits all. So the way implementation of health equity happens in Kenya, it's not the same way as it will happen in Ghana or India or, you know, whatever, pick your country. So I think that's what we've really done. It's really our ability to mobilize private sector, our ability to really be agile in the partnership models that we've created, and really our ability to work with governments, not only individual governments, but also on some of the regional platforms that we sit on, including Africa CDC. And then coming to research, you know, I liked Honorable Gwini Effa's opening remarks on you know, why we need research, why we need data, and why parliamentarians need this data to inform costing and new ways to support delivery of health services. Of course, I'm paraphrasing, but there are all these reasons why parliamentarians, you need data to inform policy, and as Honorable Kalila said, to make good laws. And so where we see our role is really ensuring that we're able to support these regional platforms that really drive the use of data. So we shouldn't just conduct research just to conduct research and have beautiful graphs and beautiful PowerPoint presentations. It's really, how are we now using this to shape policy, right? And so in coming months, one of the things that AMREF is doing, and some of you may be familiar with the Africa Health Agenda International Conference, which we've hosted for probably the last 3 years or so. And so our next one will be virtual. But as part of that conference, we are launching a commission on the state of universal health coverage in Africa. Our hope with this commission is that, and when you think of this commission, you think about commissions like the Lancet Commission on Health and so on. But our hope with this commission is that we're able to really pull out key policy recommendations using, of course, strong evidence to provide recommendations to parliamentarians, to policymakers on, you know, really driving universal health coverage in Africa and looking at this from an Africa lens, so that it's very tailored to our context, it's very tailored to the needs, it's also very tailored to just the variety of parliamentarian needs and ask across the continent. So I think I'll stop there, Priya, just highlighting those two areas for AMREF. Hope I didn't go over my 2 minutes. Thank you.
Yeah. Thank you, Lauren. That was that was a really nice overview of the role of intermediaries, and not only have you highlighted it, but I think you've provided some great examples for the role of other organizations in other countries that could actually begin to play this brokering role between these two sectors. I think we're almost up for time, so I'd like to hand the floor back to Neil and maybe open the floor for some questions, time permitting. So over to you, Neil.
Thank you very much, Priya, and thank you to our 3 final panelists who provided their own perspectives on this very fascinating subject. So it really was a very nice complement to the technical pieces that we heard earlier, and also to the more political contributions that we heard from the parliamentarians. So it's a very nice way to wrap things up. We've really come to the end of our session now, and I realize that we may be coming up to other engagements that people may have. So I think it will be good to wrap things up now. We were not able to have a Q&A, but I think that's fine. But before we part, I'd just like to recognize the participation of a few key people on this webinar, and so that we know that on this webinar, the Honorable Sabina Chege, the Chair of the Health Committee of Kenya, was able to join us, as well as Honorable Pelpuo, the Chair of the Population Committee of Ghana, Honorable Ochanda, member of the Health Committee of Kenya, Honorable Fako, the chair of the Health Committee of Lesotho, and also the Honorable Ruth Labode of Zimbabwe, who was able to participate. So it's great to have everyone here join us. And also, so I'd just like to say a thank you for everyone. And to wrap this up, really just to say thank you to the organizing committee who made this possible. And so a big, if we could applause, I'm sure we all would, but a big hand of applause goes to our very good friend Priya. But
Thank
also,
you,
you're welcome. But also to some people that who have remained more in the background. So thank you also to Desta Lakiu from AMREF Health Africa. Thank you also to Jerry Bloom from IDES in Sussex. Thank you to my own colleague Caroline Kwamboka, who heads our Nairobi office in Kenya, and thank you also to all the invisible people who have made the webinar technically possible. So thank you very much. And wherever you are, this is not the end of the discussion, but rather the beginning of it. And I look forward to continued dialogue. And hopefully someday soon, we'll all be able to meet in person. Okay.
Any photo session?
Yeah.
Any photo session?
Photo session, yes, I think so. But before we move to the photo session, one of the things that we as a thematic working group would like to offer to the parliamentarians is we'd like to continue to this dialogue. We're hoping that this is one of many. We'd love to reconvene across specific areas of private sector interest that you may be interested in. And, let's keep the dialogue going. And I'm sure, there is a lot to learn from each other down the road. So again, thank you all for your time. We can have a photo session, so I think we need to move to gallery view for that, and we can take a picture.
Okay. So,
okay.
Everyone, if they can turn on their cameras briefly.
Yes. Okay. Great.
Okay.
Bye, everybody.
Okay. All right. Thank you very much then.
All right.
Thank you, everyone.
Thank you. Thank you all for your time. Thank you.
Thanks, everyone. Bye.
Bye.